So the common thread is poverty in the middle. The woman, and the same thing in terms of gender. Financial exclusion is higher with women, higher in the north, and the same thing you also have on the head side. So there must be lessons we can learn when I was reflecting on what you want me to speak to, about how we are trying to solve financial exclusion issues and what perhaps might be applicable on the head side. So that's what I'll be talking to today. We know the data. Under mortality, one out of 10 children are dying, highest in the north, highest in northwest and northeast. Gender issues, maternal mortality, 500 out of 100,000. Embarrassing malaria, 15% prevalence, 27% of all malaria in the world is here in terms of global contribution. So the issues are clear. But on the financial inclusion side, Nigeria has made a lot of progress. Between 2010 and 2023, according to the Access to Finance research data, Nigeria moved from about 30% financial inclusion to 64% formal financial inclusion in 2023. That's a very powerful story. And what are the lessons that we can learn from what has been done in financial inclusion that we can apply in terms of health equity access? There are 10 lessons I'd like to share. Number one, the first lesson is that scale, reach, and access as a core mindset to problem solving. In financial inclusion, the reason why that program has been made is that scale, reach, and access are core mindset of problems to solve in terms of financial inclusion. The fintechs, which are the equivalent of the health techs today, see exclusion in financial services as a scale opportunity to innovate for. And it's the same way in which I believe you are trying to do. For all the problems that might be painted in terms of health equity, they actually represent scale opportunities for innovation. That is what has been done on the financial inclusion side. That is perhaps what I also comment to you on the health equity side. Number two, technology is a tool. Digital technology particularly is a tool for scaled opportunity. The economics of technology, of digital technology, is that it fundamentally crashes transaction cost. Not just on the financial side. You can apply it to commerce, and I'm sure you can also apply it to health transactions. I mean, the way to look at it is, for example, in those days if I want to do a banking transaction, I have to visit the bank. I have to travel miles away. And if you are lucky, if you are living in places like going to Ota, for example, and you have to, when you get to a bank, you have to travel and take a bike, maybe spend another 1,000 naira, pay 1 hour just to get to the expressway and to go back. That's a huge transaction cost. What mobile digital technology has done in terms of economics is that it fundamentally crashes transaction cost. Now, one of the things I like to imagine as you address health equity is that how can technology enables you to crash the transaction cost of access to health services, and what can you do with it, as has been done in terms of financial inclusion. The crash of geography, the extension of market and access through digital technology, e-commerce, financials, payments, are some of the things, and at the same time, creating affordability, because when the cost of access crashes, services become more affordable. That is what has happened on the financial inclusion side. That's perhaps what needs to happen. And I'm sure you are doing that on the health equity side. The cost of order fulfillment is also very low. Other transaction, other fulfillment, as you now see in e-commerce. So how do we use digital technology to crash as a scaling opportunity to crash transaction cost or health services? Number three, that's one lesson. Digital technology, because it enables transaction cost to be massively crashed to its unit of fractions, also enables new business models. Before, the mindset used to be, when I want to do banking, I want to go to a bank. We now say banking is no longer where I go. Banking is what I do wherever I am. That fundamental mindset thinking, that enabled by digital technology, created a lot of new business models today that are competing with traditional banking and has helped to scale access to financial services. That POS machine that you go to, that Money Point or Pay has all over the place, cost about $120. In my early days in banking, when you want to build a branch, today you probably will have to spend, even there, you have to spend, maybe buy a land for 35 million naira. It probably will cost maybe 100 million today on the high street, or 200 million. You have to build a branch probably for 500 million. A POS machine that costs just $150 can do 50% of the reasons why people are going into a bank branch. And therefore, it enabled fintechs to create innovative business model that fundamentally rethought banking services. What is the equivalent of that? I've not been in practice for a long time, but I would like to apply what's the equivalent of that in terms of health tech and innovation, in terms of new business model to enable scaled access. Number 4 is progressive regulation that supports innovators and competition. Public-private partnership. We have to commend the Central Bank of Nigeria. If we left it to the banks alone, we will not have the fintechs, because everybody will still be come to the bank, come and sign. Before you do anything, you have to, even before you get your card, you have to show up in a branch. But the Central Bank of Nigeria created new licenses outside traditional banking. They even created a department of payment services so that fintechs were taken out of out of traditional banking mindset. How can we work with health systems regulators to support innovators with new mindset? Even when there were concerns about, these people are risky, the central bank created what we call a financial systems sandbox, where there's a system where you, as an innovator in fintech, you can test your solutions on a limited basis, so that we see how to work with you, so that you don't go and create crisis if you go to the market straight. But essentially, it is how to encourage innovators in the health systems without necessarily being too afraid of the risk that they might represent. See the upside. And that is what Central Bank of Nigeria has done. How can we have the equivalent of that in terms of our regulators in the health system? Progressive regulations that encourages innovators and competition. Because if you leave it to traditional practice and equipment alone, there will never be innovation. That's number 4. That's number 4. Lesson 5 is digital public infrastructure as public good, on which private innovators will build private transaction system. Digital public infrastructure are things like digital identity systems, like NIN, BVN. There is no banking today, financial service access are scaled today because of a digital public infrastructure like digital identity, on which innovators are building their payment, credit, pension solutions. Without those things, it will have been very difficult to scale. So therefore, the public sector has its role. What is the equivalent of digital public, if there's digital public infrastructure in payment? What are the equivalent of digital public infrastructure in health systems, for which we need to encourage our public sector to build, on which private tech players can build innovative solutions, so that the cost of heavy lifting will not be too high. That's lesson number 5. Lesson 6, in terms of financial inclusion lessons for health equity, will be interoperable systems that to enable complemented and accelerated scaling. If you imagine that you can send transactions across any bank, across any fintech, there will never have been scaling in terms of systems impact if we don't have interoperable systems on the financial system industry or the financial service industry. There are different disparate siloed data in the health system. How can we bring them together as an interoperable system that enables us to complement ourselves so that we can scale access? Today, credit bureaus, switches, banks, fintechs are all interconnected as an interoperable system. What are the equivalent of that in the health system so that we can scale access? Number 7, financial solution as platforms for scaling. In the financial systems industry, people are building solutions not just for one thing. They recognize that if I build a payment platform, it can also potentially be a platform in which someone can layer access to credit, in which someone can layer access to pension, can layer access to insurance. That scale platform-oriented thinking, how can we bring into the health system? A platform is like a test bed on which you can plug many things. What is the platform system equivalent in terms of health system equity for scaling? Number 8 is ecosystem partnership. Of course, when you build a platform, you can't do it alone. One of the examples of platform I would like to give is looking far away into China. There's a company called Ping An. I don't know whether we know Ping An. Ping An is an health insurance, one of the biggest health insurance company in the world. But it started from traditional insurance, but it is now a platform business. It's transformed itself from an insurance company to an health ecosystem platform in which hospitals, pharmacists, insurance companies are now on its ecosystem platform. That is the kind of platform system thinking and ecosystem thinking that we need to bring together for us to scale health access, so that we collaborate better with ourselves in terms of ecosystem partnership and platform thinking. Number 9, of course, is data as gold. The beauty of digital technology is that it enables data to be captured at every point in the transaction process. What is the equivalent of that in health system? And how can we bring our disparate data together to turn it into gold? If data is truly gold, is data truly gold in the health system? How can we make data truly gold in the health system? By bringing them together and apply what is going to be more democratically available, AI and machine learning, to draw insights for innovation to scale access and build smarter health solutions. And number 10, last but not the least, is design thinking. The fintechs that have succeeded are the ones that brought in design thinking in the way they thought about their product. Co-creation of products with customers. In the old model, I design, I take it to the market. If they don't like it, I don't like it, well, I'll force it on their throat. In the current way in which solutions at scale are designed, I invite the patient, the customer, who should be the patient, with me into my lab. We are co-creating the solution and iterating it together until we get it perfect. This is one of the things that I helped in terms of financial system solutions that have scaled. What are the equivalent of that in terms of in the health system for health equity? Which mothers who are excluded, which patients who are excluded, so that we can have smarter solutions that can scale. Ladies and gentlemen, I hope I have not I've convinced you and not confused you that there are probably areas in which what the progress in solving financial inclusion equity will apply to health systems, health access equity. Thank you very much.